Thank everybody for coming in and joining our webinar today. This is our start of our second half of the year's webinar series. We will be having a couple more that follow on after this. Today is the NHS funding flows, health and innovation financing. And today, Steve Clarke, who is going to be leading with the presentation. Steve is a qualified accountant who has worked in the NHS for finance for 25 years across healthcare, providing providers, commissioners. Steve has provided senior finance support and leadership to a range of high value capital investments and service transformation projects. In addition to this, Steve is also beginning to lead financial planning and reporting within one of the largest NHS providers in England. For the past 6 months, Steve has supported the Health Innovation West Midlands with finance strategies. Lived in Birmingham and married for the last 27 years with 2 children at university age as well, may I add. And he enjoys football and reading and traveling. So there's a quick intro of Steve. Steve, it's over to you. Any questions that are put forward can either be placed into the chat, but we'll also have a section at the end as well where you can come off mic and ask. If not, just leave it in the chat. I will place a email link in the chat as well at the end for anybody that wants to get in contact from an innovator perspective, and also a QR code. Hopefully there'll be a QR code or a link for a feedback form. So if you could feed that, that'd be great. Over to you, Steve. Thank you.
Thank you very much, and afternoon, everybody. I can't see everybody's face around the tiles, so as Andy said, put the questions in chat if you had any. So he's done the introduction from myself, so we'll move on to the presentation. I'm going to try and cover 2 key areas. One is, how does money get into the NHS, and how does it flow around the NHS? And then secondly, a bit about health innovation networks and health innovation funding. So those are the 2 aims: healthcare funding, where does it come from, where does it go, a little bit about current financial issues, and then the second part will be sources of funding for health innovation projects. So starting at the very start, NHS funding, where does the money come from? Apologies if there are some people that have probably been working in this area for a long time and know this better than others. But clearly we live in the UK. The UK Parliament is the sovereign decision-making organisation, and the lead parliamentary political party decides how much taxes it wants to collect, and then it decides what those spending priorities are. So they collect the money in from UK residents. The Chancellor has the responsibility of setting what they call department expenditure limits, and that might be for health and social care, but it also might be for transport or defence or housing, all of the key departments, security, the military, etc., all the key departments that the government operates. So the Chancellor will set the expenditure budgets for those departments. And you may have seen there's comprehensive spending reviews, or CSRs, that tend to last 3 years, and that sets the direction of travel for the departments, and it sets out their budgets in terms of revenue and capital, which we'll come on to. So Parliament plays a key role, the lead political party and the Chancellor, all key in making decisions about where funding comes from for both the NHS and other sources, other government departments. How does then the NHS spend that? Well, we have a huge list of priorities, often competing, but key ones at the moment include the 10-year plan, 10-year health plan, sets a strategic direction, includes 3 shifts that again you may have seen in newspapers, press articles, those being hospital to community, so having less people having to go to hospital for routine tests and scans, being treated near to their home environments and where they live or where they shop. From analog to digital, again, fairly self-explanatory. So moving providers, healthcare organisations onto digital platforms and shared platforms where data can move more freely. And from focusing on the most difficult one is from focusing on sickness and treating sicknesses to preventing those sicknesses from occurring in the first place. So that's the 10-year plan strategic direction. Underneath that, there's an NHS mandate, again set by the government, and sets the objectives for the next year or so. Now, at the moment, those again are have been fairly well publicised. They are to cut waiting times, so how long people wait for a procedure, an outpatient appointment, an inpatient appointment, etc. Improving access to primary care, so your GPs, dentists, etc., and improving urgent and emergency care, so ambulances waiting outside hospitals and things like that. So those are the three immediate government priorities, and we get annual planning guidance issued before the start of each financial year that translates the strategy and the mandate into real operational priorities, and it also just, you know, it sets aside funding to help deliver those priorities. So lots of priorities, clear strategic direction at the moment though, and then this is where the money actually flows. So the government has set aside £200 billion for the Department of Health and Social Care. Huge amount of that flows into a body called NHS England. And again, if you've been keeping up with healthcare news, you'll understand that body is going to be closed down over the next 12-18 months, and the activities that organisation undertakes will be moved back to the Department of Health and Social Care or other organisations. So NHS England is the primary responsibility for healthcare provision and purchasing in England. We'll focus on England now, and then underneath that, it shows where that £196 billion actually goes. So some of it they commission directly, and by commission I mean they purchase services from providers being usually your local hospitals, whether that's big specialist hospitals, mental health hospitals, community hospitals, etc. So they commission, NHS England commission some services directly. This tends to be the super specialised activity, things like neurosurgery or complex cancers or chemotherapies and high cost treatments, transplants, those kind of activities. So NHS England purchased that from a limited number of providers, because not everyone has the equipment and skills and training to deliver those complex specialised services. But the majority of funding flows into organisations called ICBs, or Integrated Care Boards. Those are regional organisations that organise, manage, purchase and performance monitor healthcare in your region, and I'll go on to them in a little bit more on the next slide. Some money goes into primary care, obviously GPs, pharmacies, opticians, dentists, etc. And then there's a balance that goes on administration of NHS England, and then supporting national programmes and national priorities. So that's where most of the money tends to flow. So as before, ICBs, integrated care boards, regional organisations, and there's a map showing how they're spread across England. And again, if you've kept up with NHS news and developments, you'll know that these are consolidating, and the numbers presented here will be much smaller numbers as we go forward. So they're joining up together. In our region, the West Midlands, there were 6 ICBs, and we think they're due to come down to about 3. So that funding will flow from NHS England into the integrated care boards, and the money is the amount of money each ICB gets depends on its population, both the size, number of its population, how many people live there, but also factors like deprivation, the morbidity, the health needs of the local population, also age and geographical factors such as is it a big city, is it countryside, etc. So there's a whole complex weighted formula to decide how much ICBs get, and they will then buy services from local hospitals and local providers to deliver care for their population. There used to be providers of healthcare, i.e. local hospitals, mental health trusts, community trusts, used to be paid by something called the national tariff. And that was literally a price for every type of operation, every type of procedure, every type of patient care setting. And the more activity you did, the more income you could earn. As we went through COVID, and a lot of procedures and operations and services got wound down and slowed down, we moved to something called block contracts. So NHS England and ICB would give providers a block of money to provide healthcare. And now we're in a kind of mixture of several payment mechanisms, something called the aligned payment and incentive methodology covers most services that NHS providers, i.e. hospitals, will deliver for patient care. But there are others, low volume activity, activity-based, and local agreements covering any other services. But in most cases, there's a contract negotiation and between the providers and the ICBs. Those negotiations and the approach to payments for getting paid for activity, again, providers are working much more cooperatively with the local ICBs, with the local regions, with their other providers in those regions now. They're not out to destabilize each other by just doing more and more activity. They're aware that each region has a budget and providers have a clear role in delivering that budget. When they agree contracts and agree payments, it has to be backed by good quality data. There has to be some focus on health inequalities, and there has to be clear links to the guidance and the planning guidance that I mentioned before. Prices are uplifted every year. Again, costs rise, whether that's pay or drugs or non-pay consumables. And this year, often linked to inflation and inflation levels. So we're in a time of relatively high inflation over the last 2 or 3 years. The rise this year was 4.1, 4.2%. But at the same time, NHS England and ICBs also require trusts, hospitals, providers to deliver services more efficiently every year and make efficiency savings. And again, at the moment, that's around about 2% per year. 2% doesn't sound a huge amount, but for the local organisation we work for, that equates to about £130 million worth of savings to be delivered this year. That's a huge amount of money to deliver services more efficiently. Some drugs and devices are paid direct by NHS England, but say most go through this payment scheme and payment and contracting. More detail issued every year on guidance. There's this year's guidance documents there, and the link to it's there. Payment for operations and procedures is influenced by a huge range of factors. So that could be where things are delivered. So do the patients come into a hospital? Is it in the community? Prices will be different depending on the setting. So outpatients versus inpatients. Obviously the treatment type and the complexity, whether the treatment's an emergency treatment or planned elective treatment, the number of staff involved, is it a single appointment with one nurse, or is it a multiple professional appointment with lots of different types of tests? Is the treatment a day case, so you come in the morning, have your proper operation, couple of hours rest and checking, and then you're back home in the evening? Or is it an inpatient stay where you're on a ward for 2 or 3 days afterwards? All those factors, historic costs of services, also play a part in determining the overall price for a procedure. But I think that the key thing to take away is, an emergency trauma operation, somebody in a road traffic accident getting into hospital via an ambulance blue light emergency is going to cost more than a planned cataract eye operation that can be done in 40 odd minutes, and the patient can be home in 2 or 3 hours. So it's very much linked to complexity and I say the type of treatment that the patient is receiving. There's a whole this isn't for really review, it's not private information, but it's very small text. So what I'm just trying to show here is there's a whole list of prices for every different type of treatment that a patient could undergo in a hospital. or healthcare settings. So whether that's an outpatient attendance, which a first outpatient tends to run between £100 and £200 per attendance. Follow-up attendances can be £80 to £100, or whether you're having a another type of procedure. So what happens is the clinical notes will be kept, and clinical records will be kept on the procedure and the complexities and the time it takes, and the any further interventions or tests that are required, and those are all coded into a unit of treatment that has a price attached to it. As an example, here are some at current prices or tariffs for different types of treatments, types of procedures. So an endoscopy cost just under £1,000. Cataract surgery with no complexities, fairly standard again, circa £1,000. Hip replacement, again, assuming no complexities, no underlying complex health conditions within certain age barriers, can cost about £6,500. Appendectomy, £2,000. MRI scan, £250. Outpatient consultation, again, depending on is it first or follow-up, is it single or multi-professionals, up to £200. So those are some examples. Clearly, those are at the lower end of treatments when you're talking about things like transplants and complex genetic treatments. That personalised medicine, you can be talking quite easily £50,000 to £100,000 and even more per patient. But those are some examples of the payments that hospitals will receive to treat patients. Now, to look at it another way, so where does the money go in the NHS? This slide is an extract from some consolidated accounts from 210 providers, and it's 2023-24. So it's adding up 210 different NHS hospitals, providers, expenditure, and the things that you can see on here I've highlighted in yellow. So for example, you've got, and this will be in billions of pounds now, so of the NHS budget and expenditure, that providers account for most of it. £84 billion of costs on pay, staffing. There's nearly £11 billion there on drugs per year, £5 billion on premises, looking after the maintaining the buildings that these patients are treated in or patients are housed in. So this is a slightly different way of looking at it. We've looked at what providers get paid. Now we're looking at where does the money go, and clearly the NHS is a staff intensive, it's pay intensive, it relies on pay and staffing, and that's where the majority of the expenditure actually goes. Slightly different way of looking at it in a sort of different graph, different chart. Again, this is from the King's Fund, and it shows how much of the pay budget, for example, is used by the different types of staff. So £85 billion of pay, 60 odd billion of it is direct pay for staff that are employed. It's about £5 billion on temporary staff, agency and bank staff. About £10 billion goes on NHS pensions, and then there's also employers also pay tax and national insurance. So as you'd expect, it goes the expenditure goes to health visitors, nurses, science, therapists, your central functions, HR, finance, etc., property, estates, medical staff, be it consultants or junior doctors, and then support staff to help those clinical staff. So NHS employed 1.3 million staff, or whole-time equivalents or staff. And again, this is data from the King's Fund fairly recently. So I think a lot of the money that comes into the NHS ends up going into staffing and into clinical staffing and support staffing, be that healthcare assistants or corporate functions. A slightly alternative way of looking at where does the NHS money go, where does healthcare money go. A couple of years ago, NHS England started a process called programme budgeting. And what they're trying to do here is map what the commissioners and providers spend, not in terms of staff and non-pay and drugs, but in terms of types of care or categories of care. So here you've got cancer, gastro, respiratory, musculoskeletal, those types of programs. To date, they've mapped about £50 billion worth of spend, and yes, clearly other is a dumping ground for expenditure they haven't been able to map into the 23 categories yet, but they're working through that. And it shows there's a lot of money going into mental health, trauma and injuries, your sort of A&E emergency department type care. Comes out as high cost and using a significant amount, but this is quite, say, a different way of looking at how the NHS spends its money. And again, it's from NHS England, and whilst they haven't updated it very recently, it's a different way of looking at things. So I'm going to bring to close the first bit of the presentation about NHS finances, and I'm just going to go through, these are my views on what the current risks and issues are, again in no particular order, but I just want to get over here some of the challenges that your finance colleagues, NHS finance teams are having and NHS organisations are having. We touched on already delivering savings, finding savings each year, and delivering that without having an impact on the quality of clinical services, meeting the demand for clinical services, cutting waiting times, managing staff. It's a risk challenge issue, both in terms of appointing the relevantly skilled and experienced staff, freeing up their time to train, retaining those staff, and ensuring that they're working on productive, using their skills as best they can. They're not wasting time on administrative tasks that could be done by different levels or types of people, or be done by different systems. So not just the number of staff, it's the right skilled staff. Dealing with aging buildings and aging equipment, and changing political priorities and the growing complexity of new legislation, and then also working to various procurement rules. So we may have some innovators on the calls today, and they may be wondering, well, how can I sell into the NHS? And I think one of the key contacts, not just the health innovation networks, but also trying to understand a little bit more about procurement. Often you can't just go to the manager of the outpatients department if you've got an outpatients app or an outpatients pathway change or product. It will need to be the outpatients manager, but also procurement, also IT, also some level of governance. And again, we've got to prove there's a high degree of emphasis on value for money. So I think for those working in health innovation or looking to bring health innovations into the NHS, you need to think, well, which one of these pressure points is my innovation tackling? Is it going to help deliver savings? Is it going to help productivity and improve waiting times, improve the number of patients that can be seen? Which of the mandate objectives or 10-year plan objectives, the 3 shifts, which shifts does my product or my innovation support? So linking the innovation to the objectives, the 3 shifts in the 10-year plan, and the pressure points within healthcare would give you a clearer route to market, to growth, to roll out. And I'm just going to pause there for a second, take a drink, and we'll move on to the next section. So section 2, health innovation funding. So as Andy indicated at the start of the presentation, I work in Health Innovation West Midlands. We're one of 15 regional health innovation networks, and you can see them drawn out there. We cover the West Midlands. We are linked in with our local NHS providers, local NHS commissioners and organisations, and our aim is to help deliver economic prosperity, help drive growth across the country, and help innovators get their products into the healthcare systems and embedded in those systems. So our purpose, transform health and care through innovation. Again, my personal view, totally my personal view, not meant to be political, but I don't think the NHS can keep growing the budget that it has had over the last 3 to 5 years, 10 years. I think the staffing probably aren't there. It can't keep growing its staffing. We've got to do things in different ways and different pathways and do things in an innovative way as we go forward. So with a partner for applied innovation, getting those innovation projects rolled out into hospitals, rolled out into healthcare settings. And again, by doing that, we're aiming to promote the economy, to drive growth, to drive jobs, both in health and life sciences. And the way we do that is we have an innovation pipeline, and that gives us a clear governance structure. And really, whilst there's lots of information there, I think it can be summarised as the Health Innovation West Midlands role is to discover innovations, to work with those local companies in our patch, to help them develop their projects, solutioning the products and show that the products have value, and then help with deployment of those products. And then, of course, at the end, we're not going to hold people's hands forever and ever. Then those products should become mainstream in use across the NHS. So discover, develop, deploy, and then close out. And there's lots more information behind each one of those. In terms of funding opportunities, I'm not going to go through this line by line, but it's just to say there are lots of funding opportunities. I think the UK government's doing a good job in terms of making life science and healthcare innovation a key priority, both to help the NHS, but also to drive economy, to get people back into work, to create jobs in the UK, and to drive, tax revenues, etc., get people off benefits, etc. So NIHR, on each of these slides, I've put the website with the latest current offerings. NIHR have weekly alerts, weekly funding newsletters. There's currently 400 types of funds on. And again, they all close, they have clear deadlines and clear processes. I've listed a couple of examples of what's available at the moment. So NIHR is one source of innovation funding, and recommend you sign up to their newsletters. Health Innovation Accelerator, again, the website's there. They've got an open call for fellowship program at the moment, which is a program for clinical staff to get directly involved in influencing which innovations are supported and then scaled and rolled out in the regions. So again, website's there, and a little bit about that source of funding. They also have a really good list of innovations that they've currently or recently supported and rolled out on their websites. So again, worth a look. Another source of funding is NHS England. Again, they have various innovation projects outside of the health innovation networks, but they have the innovation service that can offer practical support for innovators from startups. They offer free advice and free review, and again, maybe not direct funding on this website, but lots of support and connections which can be equally as valuable. Medilink is another Midlands-based funding opportunity. Again, the website's there. They've got a cohort of schemes that they're looking to select early 2026. And again, lots of strategic guidance, business mentoring, etc. And again, the link's there. Innovate UK, run by UKRI. Lots of funding opportunities. There's current opportunities around obesity, around defence medicine, and they can provide loans for products that are close to market with strong commercial potential. Again, it's all about building UK businesses and UK jobs. Lots more summarised here. Charities, British Heart Foundation, UK Science Seed Fund, UK Charities, British Business Bank. And again, most of these can be found by Google searches and 5 minutes of research. So lots of innovation opportunities. I would strongly recommend, I know this perhaps doesn't come through well on the presentation, this screenshot, but the Health Innovation Network itself has a really good funding newsletter that sort of pulls together all of these opportunities from across the country. And again, anyone can sign up to that innovation newsletter, and strongly recommend people do that, because again, it features a huge range of different funding opportunities. This one is from May, but each month or every couple of months they come out and they've got the latest list of opportunities available there. So positive story for the UK, and positive story for small businesses, and to say that there is help available and out there. So before I finish this section, there is just a few more areas to and areas to direct you to. So again, Health Innovation West Midlands, the organisation I work for, we publish impact reports. In fact, all the HINs, all the Health Innovation Networks produce impact reports. Strongly recommend you looking at this, and because it gives you a flavour of the types of innovations that have been supported, that have been rolled out, and are now in operation across the region. So have a look at the impact report, the most recent one. There's an interesting report from called State of the Nation, and this is using evidence and insight from other health innovators from the country. What barriers did they face? How did they get over those barriers? And I say there were basic conversations with about 50 innovators, and it shows how they got their products to market and their products rolled out. Health Innovation West Midlands, lots of communication channels. There's Twitter, /X, LinkedIn, YouTube, and then the website itself. And again, recommend following those where you can, particularly if you're based in the Midlands and looking to roll out a project within the West Midlands. So to summarise key themes in innovation, it's clear that health innovation is a government priority, and that comes through in the 10-year health plan, the life science plan, the medtech strategy, and any number of documents that have been released over the last 12 months. It's clear that health innovation is one of their go-to tools for driving growth. As I indicated before, more of the money, more of the same sort of way of doing things won't be the answer for the NHS. We need to find new ways of working. And the NHS is very much now being seen as an engine for economic growth. So not just treating sick people, it has a key role in getting people back to work, helping increase UK productivity, which in turn increases tax returns, reduces benefits, and drives growth. So whilst there's really close scrutiny of NHS providers, there's significant pressures in the system. NHS providers are often focused on their day-to-day delivery of waiting times, productivity, that sort of thing, and they sometimes can't pull themselves to see the wider picture of where innovations can help, and that's where Health Innovation West Midlands and the Health Innovation Network comes in. So again, link the innovation that you may be working on or have in mind to how is it going to help ease these pressure points, how is it going to deliver against some of the objectives, and how is it going to support one or more of the 3 shifts. And at that point, I'll stop sharing my slides and happy to take any questions.
Steve, thank you very much for that. That's very informative. Thank you. We have one question in the chat, Steve, to start with, and that's from Jeff B. Have you any data on the cost or penalties in the contracts in hospitals when patients when a patient is readmitted within the 28 days?
Not to hand. There will be lots of reports done on this, because clearly that's waste, and it's much better to fix something at source, get the treatment right in the first instance for the patient, and with no errors. I genuinely don't have any data to hand. I know that there are reports on the King's Fund, the Health Foundation, think tank, and there's a couple of others, but I think it's probably one I could certainly Google and share some at a later date. But readmissions, it definitely happens across all NHS providers, and sometimes it happens for legitimate patient reasons. The treatment hasn't stuck or worked as well as planned, but sometimes there are genuine errors made during the initial treatment that could have been filtered out and fixed at the first point. But no, I don't have any data to hand, sorry.
No, it's not a problem. If you have any questions, please feel free to either drop them in the chat, or you should be able to come, if I've done this right, be able to come off or raise a hand, and I might be able to do it. But the chat is open at the moment. We did have one with regards to slides, Steve. If it's possible to share your slides at some point to anybody that's interested, is that doable? Cool, thank you. Um, those that are interested in having Steve's slides, if you want to drop that in the chat as well, and obviously we can hopefully get those across to you. Just one that I have placed into the chat is the QR code for feedback, and also the email for the discovery, our discovery inbox basically for the Health Innovation West Midlands. And this allows us to be able to communicate obviously through yourselves. And if you're an innovator and you want some more information on how we can support you, then this is the channel that we go through. So that would be great. If you do want to use that, please feel free. But we really, really, really would love to have your feedback on today's presentation. So that would be much appreciated. I can see that there's some coming in. There's another question that's just come in. Please come over the slides of the nursing and midwifery team at the BCU. Yeah, that's fine. So there's lots of people asking for slides, Steve. So very informative. We are due to finish this at 1:45, but like I say, if everyone has any questions, please feel free to raise your hand or place into the chat.
Just while we're waiting then, so yeah, using the amazing AI tools that are available to us now. So readmissions, different studies based on different methodologies reckon between 3 billion and 11 billion. I think the 3 to 5 billion seems a central, a favorite sort of estimate, but so yeah, 3 to 5 billion pounds, and that's patients that come back into the hospital within 30 days. And yes, hospitals have been incentivized to avoid that, and been fined and face penalties. So yeah, obviously that's costly to the patient in terms of time off work, in terms of their recovery factors, but also costly to NHS organisations. So yeah, somewhere between 2 billion and up to 11 billion, depending on which study and which methodologies are applied. But again, there's more information. Nuffield Trust was the other health body that I was thinking of that have published some data on that one. So Nuffield Trust, the Health Foundation, those sorts of health think tanks will have published studies on readmissions if someone's doing a paper or a writing a business case to avoid readmissions.
Oh, Steve, another question. What from Ali? What is the standard SFI for a medical department such as gastroenterology? For example, the amount which can be sent without senior governance.
Yeah, it would depend on the size of the organization and the type of thing you're looking to purchase. I could come up with a very glib value of say £50,000, but in reality, it's way more complex than that because most purchases have to be done via certain. Every purchase will have to go through a procurement route, and most purchases are done via frameworks or require 2 to 3 quotes. When you're getting above £10,000, it's very likely that you'll need quotes from multiple suppliers, and that can be hard to obtain. So between 10 and £50,000, I think the organisation should be receiving multiple quotes. Above £50,000, you should be looking to place that contract in a proper tender process or via a framework, or on the very rare occasion that only one provider is available, then that would be a single action tender, which itself is a form of governance because that requires very senior finance and operational and is subject to audit. So I think, to be honest now, anything above £10,000 requires a level of governance and the ability for medical departments, medical teams just to place orders is extremely restrictive, particularly if you're looking at a new piece of equipment. Has it passed medical engineering tests? Has it got all the right product safety and product standards, etc. So yeah, really complex question, and it shows how difficult it is for providers just to spend money on project innovation.
Thanks, Steve. So we are 5 minutes to the end towards the end of the webinar. Do we have any more questions? I'm going to ask for the first time. It looks like we may have come to the end of the questions. Oh, there we go. Yes, please, presentation. Are there any penalties for hospitals where patients missed medications? If so, where can I obtain further data on this? Also, radiology costs, are they purchased up front by hospitals via block ICB payments? Robert.
Two questions there. I'd need to dig into the contracts to come back to radiography scans. Clearly, there is a price in the price list for a number of MRI scans, number of CTs, ultrasounds up there. So there is a price list for each scan. Sometimes those scans are done as a package of care. So again, transplant patient might have multiple scans along the journey, pre and post and in recovery, but sometimes patients will come in just for a scan and there's a price point for that. Sometimes it'll be done as a part of a package of care. And then I think about the first bit of the question was about missed medications. Undoubtedly there are penalties and there are costs related to medicines mistakes. Again, don't necessarily have any numbers to hand. Would be happy to look into it and look it up. Again, I'd just be using the types of Google and AI tools that are available to all of us. But yes, it is an area where missed medication can have an impact on the outcome of treatments and procedures, and it's in hospitals' interest to make sure that medicines are taken on the required times. You probably need a pharmacist to support that, and we have got pharmacy support in Health Innovation West Midlands for exactly these types of questions. Probably not one for a finance person like myself, but we'd work with our pharmacy teams and colleagues on that.
Yeah, thank you, Steve. Robert, just asked a question. If you would put your email in the chat as well, just so we can get the slides to you that you requested as well, that'd be much appreciated. I will now say that's the second time for any questions that want to be asked. Please put it in the chat now. And then what I would just like to do as well, while I'm just giving that time, is just to thank Steve again for taking the time today out of your busy day to present to us and give us a really good insight into the financing flow within the NHS and also under the innovation financing as well. It's been much appreciated and very insightful. So thank you very much for that, Steve. Everybody else, thank you very much for joining, and also please keep an eye out. There will be another one coming in for next month, and we will do exactly the same again, where we'll look to give you an insight into how and where we can look to support you as a health innovation from West Midlands. So thank you all for joining, and thank you again, Steve, and have a good day, everybody.